Hello and welcome to the SAEM lecture series on bedside emergency ultrasound. I'm Peregrine Dalziel, and today we will be discussing some of the applications of renal ultrasound as you may use it in the emergency department. So over the next 20 minutes we're going to review the indications for performing renal ultrasound, have a look at the technique, which is essentially the same as the FAST scan, look at some basic anatomy and some scanning anatomy, discuss some pathologies you're likely to use ultrasound for, and briefly conclude with some tips on measuring bladder volume. And on the left here we have listed some of the indications for performing the renal ultrasound as outlined by ACEP in their 2008 guidelines. By far and away the primary application and the number one indication for it will be assessing obstructive uropathy in the emergency department in patients whom you probably suspect have a stone or some other pathology compressing the ureter. With experience, it may be used in the assessment of acute hematuria in patients with renal failure and in identifying abscesses and infections. With experience, more global assessment of kidney function can be made using Doppler flow and so forth. However, that's probably best used to the experienced and advanced user. On the right-hand side, we see some of the limitations. Number one there, the extrarenal pelvis and outpouching of the proximal ureter can be confused with hydronephrosis. Important to point out that ultrasound is not very sensitive for finding smaller renal stones. The renal vessels can be confused for hydronephrosis also, so something to be aware of, and you can use Doppler to distinguish those. Masses can have a very similar echogenicity to surrounding normal tissue, and the ultrasound in the ED is particularly insensitive to locating those. As with anything in the retroperitoneum, retroperitoneal fluid is difficult to identify on a simple bedside scan. And here we have pictured the starting positions for the renal ultrasound. It's essentially the same as the FAST scan, which I'm sure you're familiar with. On the patient's right-hand side, that is the liver side, we begin with the probe in the mid-axillary line around about the 8th or the 9th to 11th rib space. On the left-hand side, due to the smaller size of the spleen, we begin with the probe more superior and more posterior in about the 8th to 10th rib space at the posterior axillary line. The bottom two pictures show that it may be necessary, well, it is necessary to rotate the probe in order to find the kidney in its longest axis. The kidneys run posterior to anterior. So let's just review some of the gross anatomy that's important for scanning. The kidney is housed within a fascial sac that consists of an anterior layer of fascia known as Gerot's fascia in textbooks and a posterior layer. Within these two leaflets, the kidney is surrounded by an adipose capsule that provides some protection for the kidney against trauma. Within this fascial sac are housed the other structures, the adrenal gland, and the structures of the hilum, that is the pelvis of the kidney, proximal ureter, and the renal vessels. The importance of this fascial sac in scanning is that because it is dense connective tissue, it is hyperechoic and shows as a bright white line. This is an important sonographic landmark, as we know that fluid that is outside this white line is free fluid in the abdomen, and fluid that comes within that line is coming from one of the structures contained within the sac. It's important to point out that in most patients, the adipose capsule is very thin and is not actually evident on the ultrasound scan. And in fact, the fascial layer is often very closely aligned with the renal capsule, and they just show as one white line with no fat coming in between. But in the obese patient, the larger patient, you can sometimes see a layer of fat surrounding the kidney. Taking a closer look at the anatomy of the kidney itself, we have the outermost layer, which is the renal capsule, also thick connective tissue that is white and hyperechoic, but frequently closely opposed to the fascia and showing as one white line together. Beneath the capsule is the renal cortex, which contains the nephrons. Now, in the healthy patient, this is at least 1 centimeter thick and should have a similar, slightly darker echogenicity to the liver. If it is very much brighter than the liver, this may indicate some underlying pathology. Beneath the cortex lie the medulla and the pyramids being these triangular or pyramidal shaped structures. Now, the pyramids are bundles of the papilla, which are the collections of all the collecting tubules from the nephrons. As such, they are draining urine into the rest of the collecting system, and they will show as dark on a scanning image. They are not always evident, but in a patient who is normally hydrated or just taken on a fluid load who is producing urine, they may be quite obvious. The important thing to point out about these is that they are discrete segments that drain a wedge of the cortex. As such, they don't intercommunicate, which is important for scanning and distinguishing it from hydronephrosis. The pyramids drain into a minor calyx, and several minor calyces form a major calyx, and the major calyces all fuse to form the renal pelvis. In the normal situation, these are normally collapsed and hyperechoic, showing as white echogenic material. When there is obstruction, fluid will aggregate in the pelvis and the calyces, and they will show as dark. Important to point out that they are all intercommunicating as compared to the pyramids, and that is important. And here is those structures, how they appear on a normal scan. Just to point out, the probe marker is orientated to the patient's hand, and the footprint of the probe is, of course, on the outside of the patient's body. Now at the bottom of the screen, deep in the image, we see the pelvis. This is collapsed, as is normal, and showing as a hyperechoic area. Immediately above that, we see the pyramids, approximately in the mid-zone of the kidney, showing as dark, discrete segments as they're containing fluid. Here we see the capsule and the cortex. The capsule just showing as a white line continuous with the renal fascia in this patient that has limited adipose tissue around the kidney. And the cortex is at least 1 centimeter thick there. The liver, of course, has its own capsule, the glissons capsule. And this is obviously in a patient that has no free fluid between the renal fascia and the capsule of the liver. This lies close enough such that it all appears as one white line. Deeper to the image, we see the vertebra. And tapering away, we have the diaphragm. And there they all are labelled for you to commit to memory. And here they are in the transverse view. Just note the roughly circular appearance of the kidney. So we find the transverse view by attaining the longest longitudinal view and then just rotating the probe 90 degrees with the probe marker pointing towards the roof or the anterior of the patient. Here are the structures labelled, and I've identified that this is probably around the level of the hilum. We might see some proximal ureter there. Pyramids here, and the collapsed hyperechoic pelvis. And now let's move on to looking at some pathological images. Now I've put up there a slide of some alarming looking severe hydronephrosis, but we'll begin with the mild hydronephrosis and talk through the grades with you. It's important to point out that ultrasound is actually generally pretty good at looking at hydronephrosis, even mild grades, with quite a good demonstrated accuracy compared with CT scan. Hydronephrosis occurs when there is an obstruction along the collecting system, or an increase in pressure at some point. It causes urine to back up the urine, and gradually fill the renal pelvis. This is commonly due to an obstructing stone, but in an older patient, certainly it could be caused by a neoplasm or mass compressing the ureter, or a large AAA. A mild element of hydronephrosis may be normal if the patient is pregnant, due to extra pressure on the bladder, or if they are simply in retention or just have a very full bladder. Some things may be hydropretenders, and these are the pyramids, the extrarenal pelvis, cysts, and blood vessels, but they have other features that can help you distinguish them. Vessels can have Doppler put on to look for flow of blood. Cysts have a characteristic location in the cortex as opposed to hydronephrosis being in the pelvis. An extrarenal pelvis is a normal variant that simply identifying comes with experience with scanning. And the pyramids are non-intercommunicating. But bear these in mind as they can be mistaken for hydronephrosis. Let's look at an image and a video of no hydronephrosis, that is to say, a normal renal scan. Notice that the pelvis and calyces are collapsed on each other and showing as a white hyperechoic area. And this is evident at all points in the fan on the video. Certainly there's no collection of fluid at the base of the pelvis there. And this image demonstrates what we might call mild hydronephrosis, with just a small amount of fluid in the pelvic region. As compared with the previous slide where it was nice and collapsed and all white, here we do see some darkness on the image there. Importantly, you can't see the calyceal anatomy, which you might expect around this sort of region. And as pointed out previously, this is the amount that you might see in the quote-unquote normal states of pregnancy or a very distended bladder. And you might want to check the other side to verify that. Moving on now to moderate hydronephrosis, we can see that the pelvis has become much more full of fluid, and we can start seeing the fluid track up into the calyces. Importantly, the calyces are still maintaining some acute angles with a sort of love heart appearance. This is commonly referred to as an animal footprint or bear's paw appearance. And I note that you may still be able to see a pyramid on this picture. But certainly it isn't just the small amount of fluid in the pelvis that we see in mild hydronephrosis. And here's the slide that I began with, but this is severe hydronephrosis. Now clearly this is not normal. We've got fluid in the pelvis and proximal ureter, and it's continuous in the calyces, and it's pushed these structures out, so there's not an acute angle being formed here, not that nice love heart shape, but sort of a more rounded, blunted appearance. Now the medulla and the pyramids are gone. You can maybe see there, just underneath my pointer in that region, was a collapsed, pushed down pyramid, but the cortex still remains. So we've probably got an acute situation here, not the chronic situation. And here we see all 4 videos going at once, just to give you an appreciation of the gradation of it and how it might appear on a scan. And again, just the still images. Clearly you can see the gradation from the normal situation, some degree of fluid, much more fluid, but nice tight calyces, and finally clearly abnormal ballooned out calyces in the severe situation. And what can cause hydronephrosis? That's right, stones can cause hydronephrosis. Fortunately for us, however, as their name suggests, stones are made from hard mineral substances and are hyperechoic. They reflect sound waves, showing as bright white on the scan, and exhibiting some posterior shadowing, and I would encourage you to look for that shadowing in the first instance, as there can be other connective tissues within the kidney that also shows as bright white, but will not have shadowing. For equivocal stones, we can look at a helpful artifact called twinkling on the Doppler scan. We can also look for the flow of the ureteral jet as evidence for obstruction or lack of obstruction on one side. So there's a stone on this image. That's right, there it is. And we can see bright white with some element of shadowing behind it. Just put a note there to point out that, again, ultrasound is not very sensitive for looking at stones, in particular smaller stones. Whether this matters, whether these are clinically significant stones, is for another discussion. But just important to note that it's not so good for stones, but it's very good at looking for the hydronephrosis that stones can cause. This stone, of course, is lying in the kidney. In fact, this is a Stagworth stone, and you can see the stone material going into the calyces here. And this stone would not cause any hydronephrosis as it is not far enough down the collecting system to block the urine. And here is a stone in the transverse view. Now we can see a hyperechoic structure with some fluid behind it, being some mild hydronephrosis. When looking at the video, we can see that there isn't really obvious shadowing until just the end of the clip about there. This illustrates again the importance of fanning an ultrasound in order to get all the information you need. I'm pointing the stone out. There it is. It's a mild hydro. Observing the ureteral jets may be helpful in identifying blockage of the ureters. Now, as the ureters join the bladder at the level of the trigone, they form an acute angle and have a narrowing of the ureterovesicular junction. As the urine comes down under peristaltic pressure, this causes a turbulent flow to be set up and creates this eddying, swirling appearance that we see on the left-hand side. It isn't always this obvious, and you can put some color flow Doppler, as we've done on the right, where you see the characteristic flamethrower-like appearance of the ureteral jet. warrants pointing out that the literature tells us these urothelial jets can be quite infrequent, somewhere between 5 and 15 minutes in their cycles. In some patients they can be more frequent than that. What this means practically is that unless you stand there for 15 minutes, you can't completely declare a urothelial jet as absent. So for our purposes, in confirming stone diagnosis, or rather excluding it, we can't say that the absence of a jet makes it more likely to be a stone, unless we're prepared to stand there for 15 minutes, but we can say that the presence of a jet on one side is an indication that there is unlikely to be a blockage of the ureter on that side. Another useful trick we have is twinkling on ultrasound. Twinkling is a helpful artifact of the machine interpretation of the echoes that occur within a stone and behind it. You put the color Doppler over and it appears as if there's blood flow. This can be helpful in equivocal stones. Here we have a stone that is impacted at the UVJ and is obscured by the surrounding tissue, so we don't see a white hyperechoic area with shadowing as we would like to. But we do see some distortion, so we put the color flow on and we can see the twinkling. This can be helpful in those situations, or where there's a smaller stone that might not show up so readily on the scan. And here we include a simple algorithm for the management of someone with suspected renal stones. It's important to point out there has been no prospectively validated clinical algorithm, so any approach is probably reasonable, but this one seems like a sensible one to us, and we've adapted that from Swadron and Mandavia's textbook. So in a patient you think may have renal colic based on the history and examination and perhaps the urinalysis, we'd encourage you to do a bedside renal ultrasound and look for hydronephrosis. How you interpret the presence or absence of hydronephrosis will depend somewhat on your assessment of the pretest probability that the patient has a stone. And someone whom you think it is very likely they have a stone, perhaps they have had multiple previous episodes and they can tell you that it's very similar to these. If you identify no hydro, you may wish to go on and get a repeat ultrasound after some hydration to see if you can reveal that obstruction. Maybe give them a half a litre bolus. You may wish to also get a KUB. The old-fashioned KUB is reasonably sensitive to stones larger than 4 millimeters. But if you still identify no hydronephrosis or no calculus, this can either indicate to you that if you still think they definitely have a stone, that perhaps it's a small stone, maybe not clinically significant and not causing an obstruction. And you'll proceed to manage them clinically as you see fit. In someone you're not so sure about, where it's equivocal, perhaps an older patient or someone with their first episode, you might like to consider another diagnosis and maybe get some more comprehensive imaging. If you do see hydronephrosis, certainly if it's severe, that could be a good time to consult the urologist, as that may need decompression. You might like to get a CT before doing that, or be directed by them. In the mild and moderate category, it's somewhat less clear. Certainly manage their clinical symptoms. If they're improved, this may indicate to you that there's not much more to be done in the ED. Then you can discharge them, remembering to get serial imaging at least at 2 to 3 days to ensure that that hydronephrosis you've identified is resolving or at least not getting worse. Clearly, if they're not improved, this may be an indication for admission or discussion with urology about a potential plan. Moving on from stones to the far less interesting world of cysts. Cysts are common. Many people that you scan can recount to you that they know they have a cyst. These are usually benign, but they can be neoplastic in nature. Any tumor could have a cystic component. And if you think this is the case, or if it's a brand new finding for the patient, you may wish to go in and get more comprehensive imaging. Cysts in and of themselves are just a nephron whose collecting tubules never joined the rest of the system, so they've just sat there making urine. The importance of that is that because of their derivation, they are always in the cortex where the nephrons are found. As with anything you identify, you should fan through it. Convince yourself that it is, in fact, circular and has an ending, so it's a sphere and not a fistula or something like that. And make sure that you can convince yourself it's within the renal capsule, as you may be misinterpreting a liver cyst, for instance. Now, I've included this slide more as a warning than any educational point. What it illustrates is a non-cystic irregularity in the cortex of the kidney as identified by the capsule here, becoming discontinuous and then continuing along here with your mind's eye. We see this sort of disruption, this sort of area here. Very similar echogenicity to the surrounding tissue, and this could be easily missed on a swift bedside scan. I would really discourage you from making any conclusions about masses or neoplasm in a patient whom you suspect there might be a possibility based on just a bedside scan. If you are thinking that, then more comprehensive imaging is probably warranted. Now moving on from the kidneys, we're briefly going to discuss the estimation of bladder volume using the ultrasound. This is a useful application in the emergency department in people with retention or people who have identified hydronephrosis and should be conducted whenever you do scan the kidneys. Again, it warrants pointing out that hydronephrosis can occur with a very full bladder or in pregnancy, so if you are finding yourself identifying that, you should double check what's going on in the bladder. It has been shown in studies that simply applying the equation we see at the bottom of the screen, we can get a good estimation of the bladder volume in mils. So just taking the width, depth, and length multiplied by a corrective factor of 0.75 should give you an approximate volume. So I like to begin by measuring the bladder in the transverse view simply because it is often a bit easier to find the characteristic square shape of the bladder in that view. Please note on the left the angle of that probe. The bladder being quite pelvic, you have to get a steep angle sometimes to visualize it. We can see the width and the depth there, 7.28 centimeters by 4.64. Then rotating the probe 90 degrees with the probe marked at the patient's head, we can gain the length, 6.64 centimeters. Of course, arithmetic can be challenging at the best of times, so I offer here a simplified method in which you just round the measurements you've taken appropriately to one significant figure, multiply that together, and then add a corrective factor of about 0.7 or maybe 0.75. It won't be out by more than a couple of tablespoons to the slightly more detailed approach. And to conclude, some of the pearls for scanning kidneys in the emergency department. You might have to look for the kidneys, particularly on the left, as it can be quite far up and quite far back. Your hand can be very close to the bed when looking for this, and you might need to get the patient to turn to their right. But the kidney is there unless they've only got one kidney, but just keep looking for it. Similarly, the bladder can be quite pelvic, and you might have to get a steep angle on that probe to shoot down into the pelvis to visualize it. Rib shadows are an annoying fact of life, but you can shoot through the ribs by angling the probe, by rotating the probe, to get a better look at the structures underneath. If you can't see the superior pole because of rib shadowing, you can get the patient to breathe in, and the kidney should move down with the diaphragm moving. As always, fan slowly through structures. Counting to 6 in your head helps, 6 seconds being the typical length that an ultrasound scanner will record a clip. You can hydrate the patient before scanning if you're looking for hydronephrosis. Keep them euvolemic. And hydro starts distally. What I mean by that is, it starts at the bottom of the pelvis, and it will fill the pelvis from the bottom up. Certainly if you can see what you think is some hydro, but then beneath that you see a collapsed pelvis, then it's probably not hydro. It's probably normal fluid coming into the collecting system. And then we simply multiply those three measurements together to come up with an approximate volume of 168 mils once the corrective factor of 0.75 has been applied. And on the other hand, here are some of the pitfalls. Certainly in a patient that's greater than 50, renal colic from stones is unlikely as a first episode for that patient. So if they don't have a prior history, they may wish to indulge other possibilities. Of note, aortic aneurysm, when it presents with a painful abdomen, is most commonly misdiagnosed as renal colic. So that's just something to be aware of when assessing that older patient that might have other risk factors. When you see no hydro, that just means there's no obstruction evident when you do the scan. We encourage you to do serial studies while the patient's in the ED, preferably after a bit of hydration. Even so, about 1 in 7 patients, or around 15%, that have no hydro evident, may still have a stone, especially if they haven't been adequately hydrated. So bear that in mind when formulating your differentials. And of course, there are other things that look like hydro that aren't. These are cysts, which are spherical and occur in the cortex. Prominent pyramids in the mid-zones. These are discrete and they don't intercommunicate. The vessels, if you see them, they can be confused with hydro, but you can just put some color flow Doppler on there to see the blood flow through those vessels to identify that. And then the anatomical variant of the extrarenal pelvis. you will become more familiar with as you do more scanning. And for those of you who wish to read further on this topic, I've included my references and some suggested reading if you wish to develop your own clinical approaches to this. Thanks very much for listening. Please come back and listen again. It won't have changed, but it might be better the second time. Thank you.